11:32 here in the UK, so we're going to begin. Welcome everyone to our first Tribute to Life webinar of 2025. I can see already that there's a number of people that have joined from several of the member countries of the Commonwealth Tribute to Life. So thank you. And I can also see that the patron of our project, Baroness Finlay, has joined. So thank you to everyone. So this webinar forms part of our Sharing of Knowledge webinar series, which will run throughout the year. Today's webinar is delivered by the UK, but there will be webinars every 2 months, periodically, delivered by different regions of the Commonwealth and on a variety of different topics. So today's webinar, we're going to be hearing from Dr. Dale Gardner, who is the chair of the International Implementation Group for the Commonwealth Tribute to Life project, but he's also an intensive care consultant, so an expert in his field, and he'll be presenting on the UK's updated Code of Practice of Diagnosing Death, which has recently changed this year. A bit of housekeeping before I hand over to you, Dale. We're just going to ask everyone to keep their mics on mute. Whilst Dale is presenting, there will be time after his presentation to ask as many questions as people want, and hopefully have some interesting and engaging discussion around the topics we're exploring today. So without further ado, cameras off and mics off, and Dale, I'm going to hand over to you.
Thank you, Keelan, and thanks everyone for joining. And I'm going to thank our patron of the Commonwealth Tribute to Life, Baroness Finlay, for joining as well and watching in. I'm going to update you on the UK's Code of Practice for Diagnosing Death. As Keelan highlighted, on January 2025, an update came into force in the UK. I'm going to explain all that update to you today. So my role in that update is I was the co-chair of the Code of Practice Working Group. I work with Professor Andy Elder, who is the president of the Royal Colleges of Physicians of Edinburgh. I'm an associate medical director for deceased organ donation with NHS Blood and Transplant. My day job is as an intensive care consultant in Nottingham. So the topics I'm going to cover today is really to go through the 7 updating principles. And by going through those topics, you'll probably see where we've come to in the UK. And very much this has been one of evolution, not revolution. There aren't any startling changes in our code of practice from what we have, but there were definitely principles we went for in the updating process. So first off, death has not changed. The old criteria we used in the UK, which were come from 2008, the Academy of Medical Colleges of Royal Practice, a Code of Practice for the Diagnosis and Confirmation of Death from 2008. It was safe. We've been using it for a long time, but it would have been 17 years old this year. And there's a need for any medical guidance to keep pace with advances, evolving international knowledge and guidance. That's just normal, good medical practice. That was part and parcel. In some ways, 17 years is older than any other guideline I use in my current intensive care job. So it is good, I think, that we updated it. That 2008 code was very important in the UK for a number of issues. First of all, it removed organ donation from the code. The previous codes had mixed death and donation, and this in 2008 in the UK made a deliberate decision to stop doing that and make a code that was applicable for all deaths. In the 2008 code, it was the first time in the UK that actual clear national guidance had been provided to doctors and nurses of how to diagnose death after cardiorespiratory arrest. You would have thought that would have been like ancient, but I was taught by just a registrar who just gave me a little bit of advice when I was a first-year doctor. I had no teaching in medical school, and it was just 10 seconds worth of advice. So that's, things have improved a lot. We changed our apnea test in 2008 from what we had before to what's called internationally now an augmented CO2 test, where we start higher. And in the UK, we've continued very much the acceptance of brainstem death as a unifying anatomical functional diagnosis of death. So the code provides authoritative guidance in the UK. And what do I mean by that? If you go to the USA, the definition of death is generally given by the Uniform Determination of Death Act, which has been put into legislation in states in the United States, and that wording, as you can see in the red there, is very common in other legislations around the world. But the UK has no legislation defining death. What it has is medical consensus in its code of practice, which the courts have continually supported that medical opinion over time from the academy or its predecessor organizations before the academy, and that becomes our code of practice. When I sort of talk about the UK legal position, the UK legal position is based on a number of prominent court cases. The most important one was in 1993 was the House of Lords, which at the time was the UK's highest court, and now that's actually the UK Supreme Court. And it recognised Tony Bland, a gentleman who'd been left after a football disaster in a persistent vegetative state. It recognised him as alive because his brainstem was still functioning. And the Court of Appeal case in 2023 pointed back to the Tony Bland by saying a widely accepted medical consensus in this country for almost 50 years that brainstem death, correctly diagnosed, is the proper indicator of death in the legal sense. The contrary is not reasonably arguable at any level of court. And such it was that in 2024 in the High Court, Mr. Justice Peel very much said the brainstem tests were carried out in accordance with the code, and there is nothing to suggest that any further inquiry would reach a different conclusion. So from a legal situation in the UK, it does seem clear that the courts have upheld the code of practice over and over again as an authoritative guidance. And when we updated the code, we very much wanted to continue that tradition to write something that is authoritative. Because the Academy of Medical Royal Colleges and its predecessor organisations have been writing codes of practice for the UK for over 50 years. So 1976, 1979, the originals, 1983, which brought together those other ones, 1998, the 2008 one I've already mentioned, and now we have the 2025. A few other guidance of note. In 2015, the Royal Colleges of Paediatrics and Child Health, building off the 2008 code, gave for the first time in the UK an outline and guidance of how to diagnose neurological criteria in infants less than 2 months age. Also, the nursing staff in the UK are very familiar with the registered nurse verification of expected adult death guidance, which in many ways mirrors the actual outline, the foundation or principles and criteria of the 2008 code. And the ambulance service also uses guidance in different circumstances, and I'll talk about more about that going forward. So we've mentioned this Academy of Medical Royal Colleges. So who are they? How do they exist? So it's actually the membership body for the UK and Ireland's 23 medical royal colleges and faculties. So as opposed to some potential other guidance, which might be represented by an intensive care group, or this is driven by all the medical colleges, the sort of groups that supervise all the doctors from a professional standards point of view. This isn't the General Medical Council, which is a regulator. This is about the professional bodies. So they're wide ranging. And this code of working group that updated this code is based very much on two co-chairs, and I've mentioned myself and Professor Elder already, 12 academy representatives from that group, including 2 lay members. We had subject matter experts, we had 2 legal, 3 ethics and philosophy, 2 palliative care and nursing, 1 neuroscience expert over and above the academy representative expertise, because a lot of the academy representatives were there because of their skills in this area. 1 professor of diversity and inclusion, and a resident doctor. So this was the group, but then what we wrote as a working group went to the academy for approval by those 23 medical royal colleges and faculties. So what we sought out to do then was to clearly articulate the diagnostic criteria of whatever the circumstances in which death has occurred. This is the, the Academy's view on death. Death is the permanent loss of the capacity for consciousness combined with the permanent loss of the capacity to breathe. There are three sets of criteria, and a doctor or a nurse or an ambulance officer will use the one most appropriate for those clinical circumstances. So what we can see here, though, is that the UK criteria are unified around the permanent cessation of brainstem function. Because loss of consciousness, you need your reticular activating system for consciousness. Reticular activating systems are located in the brainstem. Capacity to breathe, it's from the medulla oblongata, which is the bottom in the brainstem, the bottom of the brainstem. And so there's a unification there, and that's in keeping with very much what the code said for nearly 50 years. So going through who can make the diagnosis, there's no legal requirement anywhere in the UK on who can make the diagnosis, but nonetheless we've given guidance, quite clear guidance. So somatic criteria is like external signs of death. You don't need a stethoscope to know that a skeleton is dead. So, and very much, this is just a competent individual, and we can talk a little bit more of that in a second. Circulatory criteria, the key here is it's generally a healthcare professional. It doesn't necessarily have to, but they should be competent in the use of a stethoscope, which by definition is generally a healthcare professional. And in neurological criteria, very much echoing guidance effectively since in the 1980s in the UK is two senior doctors who one is a consultant, the other has to have at least 5 years fully registered, and they will carry out the diagnosis for neurological criteria. But let's go through these criteria. So first of all, somatic criteria, just touch on this. Ambulance officers use this all the time. It helps give reassurance that CPR is not required, because if you've got these signs, these overwhelming physical trauma, or these time-based signs, then death is obvious and you don't need CPR or the use of a stethoscope to be sure. We do emphasize if ever that you're unsure, you should use circulatory criteria. Circulatory criteria is the most common criteria used across the UK. Again, we were writing guidance, the Academy was writing guidance for all deaths, not just donation deaths. So that's why I say it's applicable in all deaths in the UK, not just DCD. And they're basically used in care and community settings when death's expected, but also following unsuccessful cardiorespiratory arrest. And approximately 1,600 individuals a day will have their death confirmed in using circulatory criteria. So really, as I outlined right at the beginning, 2008 was the first time we actually gave national consensus on this. And there's not much change in the 2025 update. You still need the clinical examination. You still need to be competent in the use of stethoscope. You still need to observe for 5 minutes to ensure that the possibility of spontaneous resumption of circulatory function will have passed. And we talk about supplemental methods as well. To go through circulatory criteria in a little bit more detail, because I think it can be relevant for this audience. It's most relevant potentially when considering donation after circulatory death. But again, once again, it's for all deaths in the UK. First of all, precondition, you either have to have a decision's been made not to commence resuscitation, because if you think you should be doing resuscitation, you should be doing that and not thinking about diagnosing death, or attempts at resuscitation has been made but have not been successful and resuscitation has stopped. So a decision has been made that resuscitation should not continue. We emphasize very clearly if there's any doubt at all, the need to attempt or continue CPR must be considered. In that circumstance, however, when resuscitation is not going to commence, the patient might have a do not resuscitate order, or there's a decision that the CPR should stop. You need to examine for over a minimum of 5 minutes for continuous unconsciousness, continuous absence of breathing, looking at visible chest movements, and also listening with a stethoscope, and continued absence of circulation, feeling for a pulse, or by absence of heart sounds. There's no requirement that you have to like feel the pulse for 5 minutes or listen to the heart for the entire 5 minutes, because you're probably doing a bit of both, feeling for the pulse and then listening for the heart. And the key is that you have to be there. The person diagnosing confirmed death must be there observing the patient for 4 minutes, 5 minutes, and satisfied that their examination is sufficient over that period. Now, to support a timely diagnosis, and this is quite relevant in donation after circulatory death, there are ways of supplementing this, because as we know, those ones feeling for a pulse isn't as accurate as having an arterial line. Last year in the UK, we had 738 controlled donation after circulatory deaths, and this is very much how this is the same as 2008. You can use an ECG, but electrical activity will persist for quite a while once the heart has ceased to beat. And for a timely diagnosis, you look for absence of cardiac contraction or absence of intra-arterial pressure monitoring on an arterial line in a highly monitored environment like intensive care. And so I've documented that the 5-minute time can start at that once there is mechanical asystole. And this is in keeping with ancient original diagnoses where criteria for after cardiorespiratory arrest were given in 1846 by Eugene Bouchard, where he said you should use a stethoscope and listen for 5 minutes. Well, he's not listening for electrical, he's listening for mechanical sounds, the heart actually beating. And the New England Journal paper, the Canadian-led, sort of looking into the physiology of dying, published in 2021, really showed that electrics are not the same as mechanical asystole. So after the 5 minutes in the UK, we asked the doctors and nurses to actually look for absence of pupillary response to light and an absence of any supraorbital any response to supraorbital pressure. There was some discussion in 2008. We said, oh, you should always do a corneal reflex, which is sort of demonstrated in the picture just there. But there was a lot of feedback that it wasn't happening in practice, and particularly in hospices and other environments, because this is for all deaths, a great reluctance. But we felt it was important if you're making a timely, soon after cardiorespiratory arrest diagnosis. So for donation after circulatory death, as an example of that, we would always favour this. And I think after cardiorespiratory CPR, I think would also be a useful thing to do. But this shows how the UK criteria unified around the permanent cessation of brainstem function, that we are just assessing here that there is no brainstem function. Some additional considerations relevant to donation after circulatory death. Once again, the code isn't preoccupied with organ donation. It barely mentions it. This is one of the few times it's actually mentioned in the code. Last year, as I said, 738 controlled donation after circulatory deaths. And we use a procedure which is growing in the world, but in some cases of abdominal normothermic regional perfusion, where sort of oxygenated blood is given to the abdominal organs. But the key here from the code, which was in the 2008 code as well, there should be no intervention which can restore brainstem function. And with alluding to the fact that in these modern organ donation retrieval procedures, we must always ensure there is no blood circulation to the brain. So these procedures, you'll find them done in Spain, in Belgium, in the USA, and other countries emerging. And we've got very sort of, in the UK, very, very clear guidance of safety to ensure that those conditions are met. Right, after all that sort of interlude, I'm going to move us on to neurological criteria, which historically were called brainstem death, but have been called neurological criteria in the UK since around 2008, and very much is what you see overseas. Death using neurological criteria or death by neurological criteria is also a very common nomenclature. In the UK, about 3 to 4 individuals a day will have their death confirmed in this way. So compare that to the 1,600 a day who have their death confirmed with circulatory criteria. You can see how sort of new this is. When we came to update the code, it was really clear that there's been no new science that have altered any of the fundamentals to the criteria. So we saw a role very much one of evolving and updating the code rather than anything fundamental. Uh, this is, if you want to sort of understand the code a little bit more, I gave you the QR code right at the beginning, but this is another QR code, and this takes you to the Faculty of Intensive Care Medicine's website, which gives more information about that code. Most clinicians in the UK who are diagnosing death using urological criteria will access the code of practice in a sort of more practical way with these testing forms. There are two testing forms in the UK. We've been publishing sort of testing forms from the Faculty of Intensive Care and some of the intensive care societies since 2012. And that's the main way we ensure sort of the safety in the diagnosis. But when we came to write the code, safety, maintaining safety and confidence was really important. And we also looked very carefully about where necessary to strengthen the code of practice. Because across the world, there is increasing challenges to the diagnosis of death using neurological criteria. There's been an increasing legal challenge in the world. In no case has a court ruled in the world that a patient medically diagnosed deceased using neurological criteria is alive. And in the UK, we've had 5 cases in the last 3 years, and they've become more prominent in the media than previously. It seems clear looking around the world, this little saying that judges wear black robes, not white coats. And what that means is that judges don't want to make a diagnosis of death. They see that that's a job. White coats is the doctor, that the doctors, it's their responsibility to do so in a safe way. And a judge's responsibility is to interpret the law. But there have been 2 cases in the UK of clinical error, and they've been actively investigated immediately. And the UK has got a very robust, if there is any sort of concern of a clinical issue, it's investigated and national guidance is given quickly, and then that is incorporated into the neurological testing forms, which is what the actual doctors actually use on it when they actually come to the diagnosis. But also then we very much in the code incorporated any learning here and also from any cases around the world. I think the thing about medicine is we are always learning. It's these difficult cases that challenge us to actually say, can we do better, and can we close a loophole or any sort of gap in that? And we have been increasing, over the years. You see, the thought that the 1976 code of practice would be the same one we would use in 2025 is not correct. Medicine is one of endlessly improving. And as long as we remain open to always sort of getting better, I think that we are doing our duty to society well. But these were what we incorporated into the new code. They had been also in the testing forms about this condition called decompressive craniectomy, which after major neurosurgery where the bone is removed from the skull after someone with a very severe brain injury, and that can change the dynamics, what's happening in the skull. And also the Royal College of Pediatrics and Child Health work to sort of look at a case where there was quite complicated case where there was cervical spinal cord injury, which made the apnea testing unsafe. This this is in the Court of Appeal from 2023, and I think it sort of does sum up the court's view of this, and also I think a human view as well, that every human endeavor involves the possibility of error. And that is just what it's like to be human. The fact that conclusions from testing may have proved incorrect in one or more other cases underlines a need for the greatest care to be exercised. It does not lead to the conclusion that the base upon which death is to be established is unsound. I think our commitment then is to always get better and to always learn from any difficult cases. So that's sort of there when we're talking about safety and confidence and the things we've done to strengthen. But to go through it a little bit more detail of some of the updates, we wanted to complement and align across all ages, and we very much look to international guidance. These are the sort of the 4 main guidances that the updated code probably leans the most on. One is from the World Brain Death Project, which is a international community trying to come together to give criteria for diagnosing death using neurological criteria that the whole world can come together around. That was in 2020. The Australian, New Zealand and Intensive Care Societies document the statement of death and Organization in 2021, the Canadian guidance published in 2023, and the latest USA guidance in 2023. But these 4 were foundational documents, and every sort of criteria we used, we compared against them and asked the question, how can we align across the world on this? So first up, age categories and changes. So there's moderate international consensus. The lower limit to make this diagnosis is 37 weeks. Then when you transition to the adult criteria, varies internationally. So there was no international consensus here. Previously in our codes of practice, we said two months of age. The Australia New Zealand code says 30 days. Canada has two different transition points for different parts of their criteria, 1 month and 1 year, and the USA came at 2 years. So this was led by very much by in our latest code by a working group working alongside the Academy working group to look at the pediatric criteria by the Royal College of Pediatrics and Child Health. And what they said very much is, as a pragmatic solution, taking together all the available evidence, combining with the desire to align more closely to international guidance. And they were really clear with they didn't want to cast doubt on any previous diagnosis. This was mainly alignment. They recommend that transition period become 2 years of age, 24 months. So between 37 weeks and 24 months, it's almost the same as the adult criteria, except there must be 24 hours before the first clinical test, 24 hours between testing, so test 1, 24-hour gap, test 2, and no ancillary investigations in under 2-year-olds, because the evidence base is quite limited in that age group. There was a change in the apnea test, and this is where those who aren't familiar, we disconnect the patient. There's a picture of me. This is a very sort of generous family who allowed us to film their loved one, Robert, there being for his 3rd set of testing for the purposes of education. So my thanks there. But what we did in this is we in the new code is we changed the apnea thresholds and we've made it more aligned with the rest of the world. We had really no safety concerns with the current test. It's internationally described as an augmented carbon dioxide apnea test. Some codes of practice talk about following at the one we said, if it was a more timely apnea test was desired. But we saw there was an opportunity here to update the UK and more closely align the apnea test to international practice. And also, we wanted one apnea test for all age groups. So I've got this little this table for you. So across the top is the Academy code from 2008, the Royal College of Pediatrics and Child Health, which was our neonatal guidance up to 2 months of age from 2015. Then the World Brain Death Project from 2020, the Australia New Zealand code from 2021, the Canadian code from 2023, and the USA code from 2023, and now the updated Academy. So sorry for all those who use millimeters of mercury. I've tried to give some discussion here. There isn't like perfect worldwide alignment, and obviously we haven't covered every country in the world, but there is generally most worldwide alignment for an end carbon dioxide of 60 millimeters of mercury or 8 kilopascals. In my clinical practice, that's the same. It's always been the same no matter what we've done in the UK. And also a pH of 7.3, less than 7.3. So what we said in the new updated code is we will go for the same worldwide alignment to ensure greater than 8 kilopascals, pH less than 7.3. The next one hasn't got as much sort of international alignment here, but we did have a rise of 2.7 kilopascals, which is 20 millimeters of mercury. It was in our neonatal guidance, and we wanted to ensure that we could align across all ages in the UK. It was in Canada and the USA, so we have gone with a rise of 2.7. The next one was like, when do you start then? There is again very little international consensus on this. But if we started, we said over 5.3 kilopascals, which is around 45 millimeters of mercury, and we 40 millimeters around then, and then we want to rise by at least 2.7. You can get to, sorry, it's 40 millimeters of mercury. You can get up to 60 that way into the 8 kilopascals. Sorry, I'm shifting units there. So our new one was we start over 5.3 kilopascals. You must rise by 2.7 kilopascals to be an end of over 8 kilopascals with a respiratory acidosis because the pH is less than 7.3. So how long do you wait? Well, we sort of reinforce that it has to be a minimum. Interesting, in the other codes, they don't actually have a set minimum. They say they could recommend you check at a certain time what the carbon dioxide is, but that's more so they can achieve the 8 kilopascals rather than a set minimum. We felt that we should set a minimum time frame and very much follow the minimum 5 minutes we've had before. So this is a change to our apnea test in the UK, but it does, as you hopefully see through this table, bring us in closer alignment. And this is the example of the world trying to come closer together. So a little bit of detail, and apologies on that one. The other change I want to go to is the time of death. So, sorry, just go back one. It skipped. My apologies. It's just been going very slow. The time of death. So the UK mandates 2 full sets of clinical tests. It has for a very long time, including 2 apnea tests. So we used to time the death retroactively to when we did the first set of tests. So you would do the first set of tests, but the patient wasn't declared deceased at that time until the second set of clinical tests for neurological criteria was done. But then the time of death would be retroactively timed to the first set of clinical tests. And that was confusing. It was confusing to explain to other doctors and nurses. It was more confusing for families and didn't seem in keeping with international alignment, where generally you are deceased when the doctors know all they need to know to say that the patient has died. So we could have thought about doing just one apnea test, one clinical test, which some countries do, but we felt that we didn't want to move in the code, particularly because we wanted to maintain safety and confidence. We didn't want to do anything that sort of made the code seem like it wasn't strong. If anything, we strengthened every aspect of the code. So we're still mandating 2 sets of clinical tests. Some of the reasons we ended up with this retroactively timing was because in the past it was customary to repeat the tests, and then you should nevertheless repeat the test in 81 to 1998. Your 2 tests should always be performed, but since 2008, you must always perform. And given also that families are increasingly witnessing the second set of tests, we felt it was important for the families who often say they want to be there at the time of death. This made it a less confusing situation. So moving on just quickly to some other updates, clarifications. We've sort of moved the minimum core temperature to 36 degrees. We didn't have a problem with our previous one of 34 degrees. We know Australia and New Zealand uses 35 degrees, but Canada, the USA, and the World Brain Death Project suggested 36. And we think just to that worldwide alignment. We have the preconditions on our testing forms. They were added as red flags since 2008, giving warning. We've incorporated them fully now into the code, and we asked 4 precondition questions in our new code of practice about the etiology, about the assessment period, excluding reversible factors, and additional cautions among common circumstances like decompressive craniectomy. We've emphasized peripheral nerve stimulators should be used. It was in the old codes, but we're just re-emphasizing that. We've moved the minimum sodium concentration up from 115 to 125, being more conservative. Clarification, you must be able to examine both ears or both eyes. If you can't, you'll need ancillary investigation. And we've given expanded discussion on cervical spine, cord, posterior fossa pathology as well. The role of ancillary investigations is a very important aspect of all this. So we've actually have previously in 2023 given UK national consensus document for CT angio, but we sort of recommend, and this is very similar to the World Brain Death Project, recommend if you can't do a comprehensive neurological examination, if there's a continuing effects of confounders, if there's uncertainty regarding non-brain mediated movements, and to provide reassurance rather than using them as a diagnostic aid if we need to promote understanding with families. So moving on finally to communication, with patients, their families, and the public. I think this is a very important aspect. There is a whole new section in the Code of Practice talking about communication. There's lots of things written previously about communicating end-of-life care with families and breaking bad news. But we want to give some specific guidance to think about when you actually are talking about death and the way death is diagnosed around that time. Things like who should communicate the death, where should communication occur, how should the news be delivered, when should communication occur, and we gave some further reading resources to try to sort of get people thinking about this area of medical communication, which isn't as well described. Specifically for neurological criteria, we gave encouragement in the code to offer the families opportunity to observe the second set of tests. When I began offering families a chance to witness neurological criteria being performed, around 50% of families would come and observe. Now it's up in my practice to around 80%. And I don't think the families have changed. I think as I've grown in confidence with have people watching, it is important. For me, there's something about seeing is believing, and to see the fact that their loved one doesn't breathe, although distressing, can help understanding, and families generally value that opportunity, and certainly they value the fact that we are open and honest enough to sort of invite them in, even if they choose not to attend. We've given expanded discussion on non-brain mediated movements like spinal reflexes, because that is a frequent form of confusion. And we've given a short period of advice on managing requests from a family not to carry out neurological criteria or not to continue somatic support after death has been confirmed. This is not didactic at all. It talks about support you can offer families, and potentially there may be the need for going to the courts and getting legal advice to how to proceed. The way we sort of teach and promote communicating to relatives, this is from a slide from the deceased donation course we do for intensive care doctors. But the essential message we say we need to communicate to families is that we suspect death has occurred, and we need tests to confirm the death. So, for example, the scan of a brain is very abnormal and devastating. My fear is that the damage Margaret has sustained to her brain is so severe that she may have already died. Another senior doctor and I are planning to carry out some tests on Margaret to see if she will ever regain any consciousness or ever breathe again. If the tests confirm that these essential brain functions are permanently lost, this will confirm to us that she has died. That's just a very abbreviated paragraph, but to give you a flavour of us trying to get those essential messages across that death is suspected and tests are required to confirm death. In my experience, most families understand this even before the doctors do. So just coming now to an end. So the question, I haven't got any extra slides for the final one, is how can we increase healthcare professional and public understanding of how we know someone has died? And in many ways, I look to all you watching this webinar on how we as a society and a worldwide Commonwealth community can help public understanding and also people to talk about dying. We know that through our organization work, how little death is just talked about in our society, and thinking about these big issues are very important. So that is the end of the talk. I covered the 7 updating principles we really went, and hope that gives a bit of an understanding of where things are. And finally, if you want to learn more, I've given the 2 QR codes. You can just even Google the Code of Practice 2025, and those testing forms we use in neurological criteria, you will see them on the Faculty of Intensive Care's website.